Good morning, or good afternoon, or good evening, ladies and gentlemen, friends, dear colleagues. I'm Panos Kanavos. I'm an associate professor in international health policy in the Department of Health Policy at the London School of Economics, and I will be co-hosting today's session on financing cancer care post-pandemic, insights from the Cancer Policy Grants Programme. This session is a collaboration between the London School of Economics and Merck Sharp & Dohme. And my session co-host will be Janelle Krishnamurthy, Vice President Global Policy at MSD. Now, before I give the floor to Janelle for a brief introduction to MSD's Cancer Policy Grants Programme, I wanted to offer a few introductory remarks to place our session today in perspective. Now, while substantial progress has been made in cancer care over the past 10 to 15 years, demographic change will increase the burden of the global burden of cancer, and that's a reality. At the same time, scientific breakthroughs in understanding different cancers, including rare cancers, that lead to novel therapeutics have resulted in a significant pipeline of almost 3,500 potential cancer treatments, which represents a significant increase of about 75% since 2015. But importantly, this has also manifested itself in the number of launches of novel oncology therapies. A total of about 64 oncology new drug substances, new active substances have been launched globally between 2016 and 2020. And if you look at it from a trend perspective or a 20-year perspective, that total has come up to 161. Of course, that says quite a lot about innovation. But at the same time, we need to reflect on access and access to medicines. And although this has improved quite significantly over time, significant variability remains across countries. And the use of predictive biomarkers to effectively deliver precision drugs to those who will benefit from them also remains variable across both cancer types as well as countries. And of course, we must not forget the impact of COVID-19. We're all suffering from that, of course, but the impact of COVID-19 on cancer care arrangements. According to IQVIA Institute, reported caseloads from Europe, Japan, and North America are between 25 and 50% lower than pre-pandemic levels. There are delays in necessary treatments, and screenings are between 11 and 20% below baseline levels. And we hear reports from community oncologists in North America of an increasing share of their new patients presenting with metastatic disease. It becomes obvious, therefore, that having a debate on improving cancer care arrangements, assessing funding options for new therapies, and discussing affordable access from a global to local level constitute I would imagine, an absolute necessity at this point in time, given the trends I mentioned just a few seconds ago. With all that background, I would now like to invite and give the floor to Janelle to introduce herself and MSD's Cancer Policy Grant Programme. Janelle, delighted to have you on board. Welcome. The floor is yours.
Thank you very much, Panos. And thank you, everyone that has taken time out of their busy schedules to attend this very important discussion that we're going to have today. I think, Panos really laid out nicely how many innovative companies have been coming up with new interventions that have significantly improved. And I know we like to talk about outcomes for our cancer patients, but I mean, in real world terms, that means lives for our moms, dads, our nieces, nephews, our kids. And that's huge. That's important. That means, parents are able to see their kids grow up. And so that is something we take very seriously. But I think, as we all know, this takes all of us together to make this work. It is not just the innovative novel therapies that we come up with. It also is living with the disease, living with the treatment, how someone is thriving in their lives. And so we have been thrilled to be working with many of you all to look at how do we do improvements from end to end with screenings, diagnosis, treatments, and then following living with cancer and after recovering from cancer. As Panos said, that number of the cancer deaths have increased at a much slower rate, which is just fantastic, than that of the cancer cases we're finding. Many times we're seeing cases are increasing, but that's because of better diagnosis and screenings. And we definitely want to get to people earlier, sooner, so we can have the right treatment at the right time. I think, MSD we have vaccines all the ways to the treatment, and really do try to do the prevention all the ways through on looking at cancer care to the treatment. But we believe it's important that access has to be part of the discussion right at the beginning, right when we're looking at the research and development that we're doing. How are we going to look at healthcare systems? How are we going to deal with government budgets? How are we going to ensure it's actually the care will be able to be delivered? And again, that's where it comes into all of us, because I don't think any one of us have all the answers, right? And we don't have all the capabilities. And so as we, several years ago, sat around and we were talking and reading some of the great literature and practices that many of the outstanding communities and academics across the world were writing, we decided we needed to launch a global oncology grants program. And we started in 2018 with the goal of having people across the globe building a community where they can talk to each other, where we can pressure test issues, and also be science-based led. And we do know things vary in healthcare systems depending on the geography. And so just thrilled, we're about to launch our 4th cohort. We've had over 16 research grants that have been funded around, I think, over 14 different countries. And in those discussions, we've looked at very much reimbursement tools. How do we integrate together care? So we're leveraging everyone's best expertise, and also strengthening the healthcare systems in the various different geographic footprints around the world. And lastly, dealing with this global pandemic, which, as we're all seeing, people are staying home and quarantining. And that is why a lot of times patients are not getting the screenings and the regular care they deserve and need. And so we're having sicker patients. So how do we address this? And so I'm really looking forward to hearing from our excellent grantees just in a moment, and some of the amazing thoughts and ideas, and just also bringing up factors that we all need to think about. So thank you, Panos, for moderating this session and bringing us all together, and I'll send it back to you. Thank you.
Great. Thank you. Thank you, Janelle. Great pleasure to have everyone here on board, including our esteemed audience. And of course, we would want to involve you as much as possible. But let me say a few words about the structure of today's session. We'll have 2 panels. If we can switch to the next slide, please. We have 2 panels, as you can see on this slide here. In the first, grant recipients of recent years will present their research findings, and specifically, we will have 3 presentations of about 10 minutes each. I'll go through the presentations in a second. In the second panel, we'll have a moderated discussion, a participatory debate, which includes European stakeholders that would highlight key themes, enabling audience engagement with experts. We have sort of the Q&A session, if you will, but also trying to generate some consensus. Now, if we go to the next slide, you'll probably see the structure of the first panel. Great, thank you. So we will hear from 3 researchers: Claudio Iommi from Bocconi University in Milan, Italy; Manuel Garcia Goni from Complutense University in Madrid, Spain; and Maria Libura from Poland, the University of Armia and Missouri, and the Polish Personalized Medicine Coalition. Each one of them will talk about specific themes that they've been dealing with in their research. For example, Claudia will talk about the Innovation Fund. In Italy, Manuel Garcia will talk about the indication-based pricing versus product-based pricing for multi-indication products, and Maria will talk about data-driven cancer care in Poland. Now, at the end of each presentation, and in terms of trying to engage you, the audience as well, we'll have some poll questions which will seek your participation and your contribution to the proceedings today. And of course, the next panel is going to be reflecting on some of the issues raised in the first panel, and from a sort of a more global policy perspective on cancer care and cancer care arrangements. Now, we have a very packed session ahead of us, and I would like to keep it to time. Therefore, without much further ado, I wanted to invite our first speaker, Claudio Iomi from Bocconi University in Milan, to give us a taster of his research. Claudio, welcome. The floor is yours.
Thanks, Panos. Thanks, Janelle, and thanks for being invited to this very interesting session. The idea to discuss what has happened in Italy on funds for innovative medicines, so the pros and the cons of introducing dedicated funds to medicines that are appraised as innovative by the National Medicines Agency. Next slide, please. Okay, just a few words on background. We have introduced this innovation pathway in 2017. The criteria, the appraisal criteria of innovativeness are the therapeutic need, which is ranked like in France in 5 levels, the added therapeutic value, and the quality of the evidence provided by the pharmaceutical companies. And we have decided to use the GRADE system as a way of appraising the quality of this evidence. The drug can be considered fully innovative. In such a circumstance, the duration of innovative status is 3 years, or in case the evidence is not sufficiently mature to get full innovativeness, they could be considered conditional innovativeness, and they have to produce additional evidence after 18 months. The applicant is the industry, and the industry usually apply for innovativeness status in parallel with the price reimbursement status. And the main advantages of being innovative is having a dedicated fund. So basically those who pay for these drugs, which are in Italy, the regions and the healthcare providers, can secure these funds for innovative treatments. And the other very important advantage in a very fragmented market like the Italian one is having an immediate access to regional markets, since for other medicines, you need to have additional approval by the regional governments. There's some evidence on the impact, but this evidence is quite scarce. From a statistical viewpoint, 60% of applications have been approved, 35% has got full innovativeness, and 27% conditional approval as innovative drugs. Figures are a little better for cancer medicines. Consider that we have 2 dedicated funds, one for cancer medicines and one for non-cancer medicines. The spending caps have never been overcome, so basically they have been respected, but we expect in 2021 that the fund for innovative cancer medicines will be overcome. And in such a circumstances, there's a very complicated implication that make the extra expenditure go to another spending cap on medicines. What has been also found, we have published on BMJ Open and paper on this, is that the main drivers of innovativeness status are the added therapeutic value and the quality of the evidence. There has been a trend of preference for medicines for rare diseases. Consider that the National Medicines Agency is more tolerant on the application of the GRADE systems for orphan drugs because they very rarely fit with the GRADE criteria. And this is very curious. As a result, what has been found looking at the difference between the price request by the pharmaceutical companies and the price actually got from the negotiation, the difference is higher for innovative medicines. So on the one hand, there has been a good feedback in the sense that 60% of the medicines have been considered innovative. On the other hand, probably there is an excessive definition of value by the company, and the price does not fit exactly with what has been expected by the pharmaceutical companies. Consider that innovativeness status does not any effect in principle in price negotiation. It's a way of having facilitation in market access. Next slide. So our research objective was gathering the opinion of the key stakeholders that have participated in the design, the implementation, and the management of funds for innovative medicines, on the pros and cons of having funds dedicated to these medicines, the evidence gaps on their impact, and possible trajectories of reforms. Next one, please. We have carried out a Delphi study, so we have prepared a starting document with some questions to the stakeholder. As I mentioned before, stakeholders came from the main actors that have designed, implemented, or are managing the funds for innovative medicines, including the central government, the National Medicines Agency, the regional governments, the hospital pharmacists, and the clinicians. We have a special partnership, especially for the communication and workshops with the Italian Associations of Medical Oncology. We managed this Delphi study in 2 rounds. So we have a preliminary feedback, but to reach, like in any Delphi panel analysis or study, we have to organize subsequent steps. And the second step was sufficient to get an agreement. And the agreement was reached in October 2020, presented to a dedicated workshop and published in a paper on global and regional health technology assessment. Next one. So apart from discussing the evidence, the problems, the costs, and the pros, at the end, our panelists have given some recommendation for both politicians, for the Medicines National Agency, and for all actors dealing with funds for innovative medicines. The first recommendation is that this innovative fund should be maintained also in the future. Obviously, there has been a huge discussion over the circumstance that dedicated funds could be considered rightly as a typical replication of a silos approach. So we have spending caps on drugs, we have a spending cap or funds for innovative medicines, but these funds were considered as a clear signal to the pharma companies of prioritizations in market access for treatments that have been appraised as innovative through objective, reproducible, clear criteria, and consider that all appraisal documents are published on the IFA website. The second main recommendation is making the system more simple, because having 2 dedicated funds is too complicated for those who manage them. And also, since the 2 funds are not communicating vessels, in case you have an extra spending on one fund, you cannot compensate with a possible underspending on the other fund. And this recommendation has been actually implemented because the Parliament has recently voted to merge the 2 funds in one unique fund, which is dedicated to innovative treatments, regardless they are onco or non-onco. The third discussion concerns the innovativeness status. One concern of clinicians is that once the innovative status is expired, the risk is that there will be not sufficient fund to cover the past innovative treatments. So the panel has suggested to prolong the length of the innovativeness status over 3 years, provided that there is a clear definition of criteria why this is done, including, for example, the circumstance there are no valid alternative treatments. And second, considering the new entrants. So provided that this extension will not create problems in funding new medicine entering in the innovative fund. The next and last one, please. Another very domestic-based discussion was whether this fund should be taken from what has been already allocated to the healthcare system in Italy, or on top of resources allocated. And the panel has said that they clearly come from additional or extra resources, because other resources should be allocated through current expenditure and other objectives. Another point is that the system should carefully monitor the prescription of these medicines. Consider that innovativeness status is given per indication, and that could be indications innovative and indications which are not innovative. So there's a risk that the prescribing behavior of medical doctors is given by whether they have resources on innovative funds or not. So it's important understanding whether the prescription is driven by science or need of patients and not on the way the funds for medicines are organized in Italy. Another big issue is that despite we have a rule stating that there should be an immediate access to the regional governments, there are still persisting differences. Some regions are creating barriers, and the idea is to collect further information on whether this will persist also in the future. And finally, since at the moment, procurement of innovative medicines can be managed only by public hospitals, whereas we have a number of private accredited hospitals by the National Health Service, the idea supported by the panel is extending the possibility of using these medicines also in these hospitals, and consider that private accredited hospitals are differently distributed across regions. So there are some regions which have experienced more troubles and more problems in managing this fund. So these are the general recommendations. The paper is an open source paper. Unfortunately, it's written in Italian apart from the abstract, but I am obviously totally available to answer to your possible questions. Next and final slide. And this is my email address. Thank you. Do I have to launch the poll?
Thanks, thanks, Claudio. Yeah, I think it would be good to see what the audience makes of the questions that we have prepared here. Okay. And thanks for the presentation. Great. I'll go straight into the question, and will invite the audience's participation. The question here reads as follows: in your opinion, a dedicated fund for innovative medicines is useful to prioritize access to innovative medicines, should be viewed critically since it introduces a silo budget approach, or I don't know. You may all vote now. Okay. And okay, we'll wait a few more seconds. It's going up or down. It's about 72%. So from our Gastein colleagues, to consider these to be the final results.
Okay, so 2/3 thinks that it is useful. Yeah, I think so, even if as a health economist, I would prefer having a global budget. But if you use a dedicated fund as a clear signal to provide prioritizations in a very fragmented system that the Italy one is the right solution, it should be not replicated for many other medicines. That's my personal opinion. Thanks for your thought.
That's a very useful one. Let's launch the second question, please. In your opinion, the criteria used to assess innovativeness in Italy, the first answer is are fine. Secondly, are fine, but the quality of evidence should not rely on the grade system. Thirdly, are fine, but the added value should include benefits other than the therapeutic value. And I'm a bit mixed up here because I didn't manage to read the question before people started to vote, but you can see the answers nevertheless.
Yeah.
Okay. There's also, Claudia, once the audience is voting, there's also an interesting question you. Many thanks for the very interesting presentation. Are patients involved in the provision of innovativeness status? Is there a publicly available list of the predefined criteria used to confer the innovativeness status? Maybe you can reflect once we've given sort of a couple of comments on the responses here as well.
Yeah.
And we have to fast track to the next presentation because we're running out of time.
I mean, we're running late. So I think that, patients are not involved because appraisals is mostly, is only used on clinical value. In case you extend to non-clinical value, including quality of life, but also acceptability to patients, obviously patients and patient representatives and experts should be involved. Yes, criteria are clearly defined. There's a document which specifies criteria. There are statistics, and all appraisal documents are published. So the National Medicines Agency declares why innovativeness status has been given or not. And they also report contrasting opinion into the commission, which are very useful.
Fantastic. So we do, thank you, Claudio, and we do have a little bit of a variability here in terms of the spread of responses across the different options. So added value should include benefits other than therapeutic value. I think that's something that deserves a lot of debate, and I suspect this is something that you may be reflecting on and taking further in the days, weeks, and months to come. Second option here, value for money and or budget impact. I don't know if the innovativeness should also include those dimensions, but I thought in Italy it was part of the negotiation process between the supply side and the demand side. The demand side represented by AIFA, I suspect.
Yeah.
Okay. Thank you from our
much.
Audience, and thank you, Claudio, for a very interesting and very exciting presentation on a topic which is definitely attracting a lot of interest because we're talking about a kind of value framework at national level. Super. Can I move on to the next presentation, please? And that's Manuel Garcia Goni from Complutense. Over to you, Manuel.
Hi, thank you very much, Panos. Thank you very much, Janelle, also for inviting me to present in this forum, in Datainformed. It's a pleasure to be back in this forum, although I would like to be there in person, but hopefully next time.
So do we.
Yeah, hopefully next time. So thank you also to LSE and MSD for the organization, and to MSD for this MSD International Policy Grant Program that we take part of it. Next slide, please. And next one, let me start with the motivation. Next slide, please, and a couple of bullets more because we have a couple of figures. First of all, I would like to motivate with some data from Spain. And well, in Spain, we, as in many other countries, we are concerned about the evolution of healthcare expenditures, and within healthcare expenditures, specifically in pharmaceutical expenditures. Here on the left, you have a figure in which you see how the relative weight of pharmaceutical expenditure at hospitals is clearly increasing in the last years, while the relative weight of the pharmaceutical expenditure at offices of pharmacy is slightly decreasing. Still, the expenditure in pharmacies is still higher than at hospitals, but the gap is getting closer. And the main reason is because of the innovativeness of the products that are being dispensed at hospitals. And you can see that clearly on the second figure on the right, in which you see the average prices. So the blue line is the average prices of medicinal products which are dispensed in pharmacies. The price is very low and quite constant. But if you look at the average prices of medicinal products at hospitals, well, the price is continuously increasing, and that's because, again, this innovativeness of the products. And many of those are cancer treatments. In fact, cancer treatments are getting more and more importance in Spain in the pharmaceutical spending at hospitals. Last year, they were 21%. The 21% of all pharmaceutical spending at hospitals consisted of cancer treatments. And well, next couple of bullets, please. And basically, if you look at them, many of those are multi-indication treatments, because right now, about 75% of all oncological treatments are already authorized in Spain for, well, in general, for several indications. Because of this, well, Panos was introducing this, no? we need to improve the access to innovative treatments to patients of all the indications for which this medicine has been approved, authorized. But at the same time, we need to promote the sustainability of our health systems. And well, in Spain, there is an increasing debate on whether we should be using indication-based pricing or not. It's quite important to look at this figure, because now in Spain, we are gonna discuss what to do with this. Next slide, please. In order to do that, basically what we did was first a literature review of what has been done in other countries. Then we conform an expert panel. This expert panel was completely multidisciplinary, in which several stakeholders were taking part. We have patients, payers, clinicians, health economists, the industry, but also pharmaceutical provision and cancer strategy at the national level. Those were represented in the expert panel. The point of view of all the discussions was completely practical. We wanted to see, with their experience, what should we do in order to improve things here. And we had 2 direct discussions in 2 meetings, always towards the practicality of the different alternatives. The 2 alternatives that we were discussing were a single price, so product-based price, versus indication-based price or indication-based discounts for multi-indication products in Spain. The scope, and we decided that in the meetings, was just to talk about the pros and cons of the both alternatives, but without any intention to endorse one or the other alternative. The reason for that is that it's a health policy maker, the one that should take these decisions, and the intention of this panel was to help with information, with technical information, to health policymakers to take this decision rightly, but without willing to endorse one or the other because of the composition of the panel. And it's very important that we wanted to be quite neutral in our report, basically, because the main message that we had is that we needed to implement much better in Spain, and structurally the application and implementation of economic evaluation. And also because no matter what happened, no matter whether we go for one or the other alternative, we still think that there should be private negotiations between the payers and the companies after we set the price, which is the listed price. Next slide, please. And well, next couple of bullets. So basically, if you look at the next bullet also, please. If you look at the different options, we wanted to see what happened in other countries. Well, in the countries with product-based pricing, as Germany, Belgium, or Netherlands, they had different approaches. In Germany, they have taken into account the economic evaluation and the added value by the product in for different indications, but through a weighted average formula. While in Belgium or the Netherlands, they are applying multi-year, multi-indication treatments. And then if you go to their side in the indication-based pricing, you see Italy. Italy is the country in which basically you have indication-based pricing, well, different prices or different discounts for the same product with different indications. Now, in terms of regulation, and in order to check which type of alternative would be easier to implement in Spain, I have to say that in the panel we discussed, and we find that indication-based pricing would be a bit more difficult to implement in terms of the regulation. Why is that? Well, basically because today in Spain, we have just one single price for the product. And if we want to change that, then maybe we should have some more issues with the regulation that should be changed. In any case, we also agreed in the panel that this problem of the regulation is not a major problem, and it should be easily solved. So that shouldn't be a big problem. Then, as a health economist, I have to say that the philosophy we think should be close to the setting prices, trusting on the value-based price. So basically, we want to get closer to value-based price, and the indication-based pricing strategy is going to be better than the other one for this, because for each indication, you are going to set a price which has to do with the value. So that should be closer to value-based price. Although if you go to the product-based pricing strategy, as in the case of Germany, for example, with a weighted average, you also take into account the value. So again, there are some pros and cons and in both of them. But again, the most useful thing to do is to apply the value-based pricing. Maybe the risk that we thought that would be important if we go for product-based pricing is that maybe we get rid of economic evaluation and just apply the simple price-volume agreement that we have done many, many times. And that would be maybe not as appropriate as going for the economic evaluation technique. With respect to the challenges, well, if you go to indication-based pricing, there should be some challenge with arbitrage between the indications, although we think that it's not a major problem, and you can get rid of that problem with the registry of clinical information. Now, implementing that registry, again, that is going to be a challenge itself. But the challenge that we would have if we go for the product-based pricing would be that we would need to avoid the strategic behavior by companies in the order in which they submit their dossiers for the approval or authorization for financing of the different indications. And that is perceived as a very high risk for the payers in Spain.
Manuel, 2 minutes, yeah.
Sure, no worries. Then it's very important that our conclusion is that we should go maybe for economic evaluation, and that economic evaluation should be followed by transparent guidelines and be quite homogeneous, so that we can reduce this distrust that sometimes we can perceive between payers and the companies. And in order to do that, some common challenges for both alternatives. We need to have a very extensive registry of patient data and clinical information per indication. That is going to be costly at the beginning. Maybe we want to combine our economic evaluation with budget impact analysis. Here we can get back to the Paris Volume Agreement again if we want, and also maybe multi-criteria decision analysis or specific funds as the one that Claudio, for example, was discussing earlier. And also we thought that we would need to take into account the degree of competition to each different indication, each different relevant market. Also important, the structure in order to perform all the economic evaluation should be important because it's not only about setting prices, but also revising prices in a periodic way. So it's going to be a long time to basically do all this work and perform all this analysis. And we will need to evaluate also, change also and evolve in our regulation. We have to say that there is a new tool in Spain that was implemented at the end of last year, which is named Revalmed. They are trying to perform the economic evaluations, but it's still very early to evaluate whether that is going to be successful or not. We will see that in the future because the structure has to be huge, and we will see if that is successful. And many health economists, as myself, we endorse the creation of an independent agency of the type of the NICE in England for the case of Spain. So next slide, please. Thank you very much for the attention, because that is basically what I wanted to say. And let's see how it goes with the poll now. Thank you, Panos.
Fantastic, Manuel. Thank you for keeping to time. And again, very exciting. I was interested to see how MCDA can be applied. I obviously heard a lot about the economic evaluation in the Spanish context. It will be interesting to see what our audience feel about the questions that are going to come up. So we've got a couple of questions. One of them, the first one here, in your opinion, the use of economic evaluation should be included in the price setting of innovative multi-indication medicine in a dedicated fund for innovative medicines. Bit of a mouthful, but I think it's important to think about the options here. Only if we want to implement indication-based pricing, both with indication pricing and with a single price for all drugs, for all indications, sorry. It's enough with price volume agreement, or I don't know. Let's see.
Let's see.
It's not an easy question, I must say.
It's not.
although obviously, just commenting very quickly, it is easier for decision makers sometimes, assuming that these are the final results. My own perspective is that it's easier for decision makers to perhaps consider a single price for all indications, but obviously the question is, how do you arrive at that single price? Because it's sort of it's a fuse price, right? And that's a relatively straightforward option. Janelle, you're on mute. If you wanted to intervene, feel free. But it seems to be yeah,
I think it's good to. I don't want to skew the audience here, but obviously that's why we're all here together, because this is very
absolutely. We've finished a piece of work on indication-based pricing, so I think some of my colleagues may have some things to say about that. But it's interesting results nevertheless. So both with indication-based pricing and with a single price for all indications. Interesting to see how the feasibility of that might work in practice. Yeah. Nevertheless, here are the results. Very interesting, and we thank our audience for that contribution. I think we have another one, and we'll go through that very quickly. In your opinion, the focus in Spain should be placed on, based on what you've heard, of course, economic evaluation and the value of innovative products per relevant market, indication, multi-criteria decision analysis, budget impact, specific fund for innovative medicine. So you have a lot of options here, which are quite interesting, also linking it to the previous presentation by Claudio. So let's have a quick look at what is going on. And whilst the audience is reflecting, I wanted to also thank Claudio for responding to the questions in the Q&A part. So back to the audience, feel free to ask participants any questions, which depending on time, they will be able to write a brief response. I think reflecting on the results here, half of our audience thinks that we should have a multi-criteria decision analysis. Of course, the MCDA relates to the inclusion of criteria beyond costs and or effects. So we are looking at other dimensions of benefit, which are captured more holistically, but also in a less ad hoc way compared to what is maybe happening today. And with specific scores and weights, and obviously it becomes much more of a complicated function. But it's an interesting methodology, and so it depends on how we mean MCDA, because it can mean it can have different connotations. So about a quarter of the audience think of economic evaluation, and fewer relating to budget impact and specific funds for innovative medicine. I don't know, Manuel, how does that sit with you? Very quickly, one sentence.
I'm surprised at the multi-criteria decision that many people have, half of the people have answered multi-criteria decision analysis, because it's complicated. It's complicated to implement. And but anyways, it's interesting to add many attributes and many features into the formula. But I think in Spain we should go step by step, and the first step should go for economic evaluation, because budget impact is something easier to implement, and we kind of already do that. But the economic evaluation, I think, is the first need, and then we can add the others also and combine them.
Thank you. And budget impact may be difficult because the way you fund medicines is at comunidades autónomas level. In other words, the regions, as opposed to funding at central level, although there may be some interesting connotations there. Manuel, finishing off, there is a question for you in the Q&A. If you wanted to reflect on that one and give a response at your convenience, that would be great. We don't have time to look at it right now, but I would like us to move on to the third presentation from Maria, if that is okay.
Thank you very much for giving me this opportunity to first conduct a grant, and thank you to MSD for this grant to Polish Alivia Cancer Foundation. And this is going to be a very different presentation, because it's not on economics, it's more on social and institutional determinants of turning data into policy. And this quote in the title is actually a quote, it's a quote from one of our respondents who was a patient from a patient organization, and that was the way she described the necessity to take important medical decisions on individual level while lacking knowledge. And I think that it very nicely translates into the bigger challenges on the better and macro level of healthcare systems. So we do need to make all those decisions, whereas with lack of knowledge or insufficient knowledge, it's a bit like cycling while blindfolded. And the promise of data-informed health policy is the promise that this is going to change, which we will see what we are about to do. Next slide, please. So the background, as a background, so what you need to know is that cancer care is one of the biggest challenges in the healthcare published system, and there is this unfortunate pattern of low incidence, high mortality, and low survival found in the cancer population in Poland. And the policy initiatives up to now have failed to break this pattern, and therefore data-informed innovation and decision-making in oncology, are those areas where high hopes are held. That this is somehow that introducing more data-driven decision-making on all the levels in the healthcare system will help to identify the problems and tackle them in the better way. Next slide, please. So, so the main goals of our analysis were to paint as if the landscape of data collection, decision-making, and designing policy in Poland as seen by the main stakeholders in the system. So we invited health policy decision makers, patient organizations, key clinical opinion leaders from the main cancer centers in Poland, as well as specialists from the field of health IT and from the legal profession. And we asked them, as you will see, in 2 ways: to identify the main challenges to a more comprehensive data-driven policy in Poland, and then to come up with recommendations for the country-specific recommendations. So next slide, please. So we held 2 workshops with those key stakeholders, and which were followed by semi-structured interviews with selected representatives of those stakeholders. And later on, we also had a questionnaire directed to patients, because one of the problems that we identified was the willingness to share health data among Polish cancer patients. Next slide, please. And the results can be grouped under 2 headings. So first were main technical challenges, and there was general agreement that among all the stakeholders that these are the technical challenges that need to be overcome. So like the scope of the collected data, which was judged to be too narrow, a big issue of the fragmentation of databases, which is quite interesting because Poland has a quite centralized healthcare system, and yet, but that's on a very, as if on the macro level, whereas at the providers level, and among regions, you have very different subsystems. And what's more, those earlier policy initiatives, some of them actually contributed to the fragmentation of databases. Another big problem that everyone will see was low data quality, and we'll return to the reasons behind that on the next slide. As well as interoperability, but everyone is complaining about that. Here, the additional problem was that those subsystems that collect data for settling insurance claims were in no way connected to other healthcare data and patient data in the system, which meant double or triple work to the healthcare teams on the clinical level, which in itself contributes to the low data quality later on. And there was perceived insufficient coordination of data policy initiatives. So again, they were discontinued, or there were such big projects at the National Cancer Registry, which until quite recently was actually run on a voluntary almost kind of basis. This changed a couple of years ago, but that also contributed to the general picture of data as not being treated as important. This is changing, but the past, the past dependence from past experiences is still there in the healthcare system. And also another big problem was lack of access to data gathered by other stakeholders, which resulted in lack of the feeling of ownership of the data. Next slide, please. These are this is the second group of results, and here we can see the divergences appearing. So these included the goals, the process of data collecting, the processes by which data should be collected, and also the how those data should be analyzed and what purposes knowledge from resulting from data analysis should be used. So, for instance, while policymakers were focused mostly, almost, on data for cost containment of the healthcare system and short-term efficiency of hospitals, the clinicians pointed out that those demands related to introducing such data into the system to set claims or to support those cost containment programs, for instance, therapeutic programs, were often irrelevant to the daily practice. So they were actually burdened with heavy administrative workload without seeing any.
Maria.
Yeah, I'm about to finish. Right, without seeing it translating into the clinical work, so they couldn't see the connection. And the patients' organizations were concerned with service quality and patient experience, and many interviewees complained of the limited access to the data that there is in the system. And there were very few ideas of what to do next at all. Next slide, please. So the data landscape taken together is comprehensive, but the perspectives of particular stakeholders are very fragmented. So they are complementary, but it seems that there is no bird's eye view in the system, which is quite interesting in itself. And again, when you look at the key issues as listed here, so there is limited overlap between those perspectives as what to collect, how to collect, and what to do with those data. Next slide, please. Okay. Yeah. So the key takeaways. So given the fragmentation, what is needed first of all is a comprehensive long-term data strategy for oncology that should be part of a wider strategy for the healthcare system. But in oncology, it has there are special needs that need to be addressed. And what we also need is a mechanism for dialogue between those stakeholders, because they can't see what the others see, right? And they remain blind to those perspectives. And some conflicting views arise from lack of this dialogue. And then certainly the implementation of data interchange and collection standards specific to oncology is a must, as well as encouraging data sharing and granting clear ownership rights and benefits to all those data holders. because that was one of the reasons why data were low quality in some cases, that those who actually provided them into the system couldn't see themselves as having some ownership of the data. And also the financial side is crucial here, as up until now, it's doctors and clinicians who are often assigned this kind of work, and this needs to change. The case of pediatric oncology in Poland, where we do have this sort of financing, shows that a lot can be done and improved if this administrative work is taken away from clinicians. And also we need a legal framework friendly to medical registers. This is a big issue in Poland. I don't think I have time to discuss it at this point. So we can now move on to the polling question. Thank you.
Thank you, Maria. And since you mentioned the polling question, let's go straight into it. And thank you in the meantime for a great presentation. I'll come back to one or two points I wanted to raise later on. But in the meantime, data collection and analysis systems predominantly should be centralized and managed by MOH, financed publicly but developed and managed locally, financed and developed locally in public-private partnership, or developed locally while central institutions only provide data standards. I think it may take a wee bit of time for our audience to digest the options, but feel free. Let's see if there's any variation. I thought so.
Yeah, that seems to be the direction, right?
Mm-hmm. Okay. Did you expect the kind of response, that kind of response, Maria?
Centralization is the new black, yeah.
Okay. Great, but I think in your presentation you raised a series of critical points. We are talking about evidence-based policy and evidence-based healthcare. So having that critical information is absolutely paramount. So I think you've done an excellent job in actually highlighting some of the challenges here. In addition, we are talking about the transition into digital healthcare, where there is connectivity between purchasers, providers, and patients, obviously, with their own data and information, so that we can make better decisions.
If I may, but then, yeah, it was quite interesting that for healthcare professionals, the world of health data was restricted to the healthcare system mostly. So it was only people from IT who could see that, yes, you will have this inflow of information from other sources from outside the healthcare system.
Right.
Yeah. Mm-hmm.
So so again, in my mind, it raises a lot of questions about integrated care pathways, about care coordination, and how best to address needs of specific types of patients or specific patients, those who present the greatest risk, and of course are in need of urgent care and urgent care arrangements. So unless we are able to resolve some of these issues and come up with solutions at system level, with any one of those options, but obviously our audience here has given us a few pieces of food for thought. We're not going to make that transition. It remains dubious as to whether that connectivity can be achieved, so that we can improve care arrangements, improve the way we organize care, and so on and so forth. So I think therefore. Overall, we had. Thank you, Maria. First of all, I think we had 3 extremely exciting presentations reflecting on specific issues. One relating to IBP in the context of Spain, indication-based pricing, and the challenge, because we see a lot of products coming up with multiple indications. We had, before that, we had the Innovation Fund in Italy and the criteria that relate to it, and what is included and how we make decisions and so on. And thirdly, the data and the data-driven aspects and the challenges thereof for improvements in the direction of cancer care in Poland. That practically completes the proceeding, so to speak, of the first panel. But our panelists remain here, and obviously will contribute to the discussion that ensues in the second panel. What I would like to do now is bring to the fold, so to speak, our stakeholders. If we can put the next slide up. Yep, that's great, thank you. It's not a separate panel or a separate panel arrangement, but it is really bringing into the discussion Antonella Cardone from the European Cancer Patient Coalition, so that we can have a broader reflection of how people see what they've heard on cancer care policy. Francesca Colombo from the OECD, who is the head of the OECD Health Division. Stefan Krenen, as member of the part of the European Commission's and task force for Europe's Beating Cancer Plan. And of course, Janelle Krishnamurthy, my co-host here. Ladies and gentlemen, of this particular panel, you've heard a number of interesting things, I hope. I found them very exciting. I just wanted to pose a question to you, and specifically to reflect on your own experience as stakeholders from your own standpoint. And give us a few thoughts and ideas about the advancements that have been made, but also some of the outstanding challenges in the delivery of cancer care. In your view, has health policy responded sufficiently to the pace that we've seen of innovation and emergence of new cancer treatments over time? And what has been happening with the emergence of big data, and how we're using this and the technological advances in care management? Has that been adequately reflected, or has that contributed to these arrangements or not? What I would like to do is perhaps invite Antonella. Antonella, welcome. And maybe you can give us your first thoughts on that, if possible.
Sure. Good afternoon, and thanks for giving me the opportunity to bring to this panel the patient voice. Well, in the past 5-10 years, we have made a tremendous progress in cancer prevention with new cancer screening techniques and more cancer screening policy across Europe. We have made innovative cancer diagnostic tools, including biomarker testing, available to more cancer patients. We have new treatments that were science fiction a few years ago and now are available to an increased number of patients. All this also thanks to the huge development of artificial intelligence and big data. So I can also mention that we have today more cancer patient associations and more mature and representative cancer patient associations. Just thinking of ECPC, which is the association that I represent here, the European Cancer Patient Coalition, we have moved from less than 50 members 10 years ago to over 470 members today from 50 countries. And during these years, we have advocated for early diagnosis, best quality treatment and care, and to have patients participating in decision-making and treatment process. Among a few achievements from the patient side, I can report the involvement of patients in the HTA process, still far from the optimal, but it is happening. The shared decision-making concept, which is slowly becoming a reality. The patient preference considered during the drug cycle, the informed consent form co-created with patients, the consideration of cancer-related complications and comorbidities as an integral part of the cancer care and survivorship, the overall concept of value-based healthcare, and I could go on for a long time. But despite all these improvements, still cancer is the second leading cause of mortality in Europe. And if we do not stop the current trend, it will become in a few years the leading cause of mortality. So to stop this trend, we needed to make sure that all the advancements made in prevention, screening, and treatment are accessible to a wider population. For us, it is inconceivable that a life-saving treatment is available on day one in one country, and after several years, up to 12 years in another country. Or that a biomarker test that can accelerate an accurate diagnosis and help to identify the right treatment immediately is accessible in one country and still not in another country in Europe. Unfortunately, the innovation in diagnostic tools and treatments or the fast advancements in the use of big data and artificial intelligence have not been followed by an adequate advancement in health policy. If we look at the screening programs, they are not uniformly implemented across Europe. If we look at the biomarker testing, the use of data is not sufficiently regulated homogeneously in the EU, creating misconceptions in the population. If we look at innovative treatments such as CAR T-cell, there is a gap in the regulations that is slowing down tremendously the development of the treatment. On the other side, the research is often slowed down by strict or insufficient or unclear regulations on how to collect, manage, and share data. The GDPR is definitely a good tool, but it is interpreted and implemented dishomogeneously across Europe and even within the same country. So this is why we have a lot of hope into the Europe's Beating Cancer Plan as a fundamental tool to reduce, if not eliminate, inequalities across Europe. Also providing a framework of policy and incentives for their implementation across Europe. And I'll stop here.
Thank you. Thank you, Antonella. I think you raised a lot of big issues. And I think the last issue that you met, there are lots of access issues and access delays issues, differential regulation, about treatments, about biomarkers, about biomarker testing and availability, and so on. But of course, also issues around inequality. You finished off by talking about Europe's Beating Cancer Plan. And I think that, to me, invites a commentary from Stefan. We have Stefan here, Stefan Kranen from the European Commission, member of the task force.
Hello.
Maybe Stefan, if you're there, right?
Yes. Hello.
Maybe if I can turn to you.
Yes. Good afternoon, everybody, and thanks for the invitation to speak here. Well, just to continue on the issues that Antonella raised, and that was exactly the reason why we came up with the Europe's Beating Cancer Plan. It's not let's say a health-driven plan, but it's a plan that is developed with all the other key policy departments of the European Commission, exactly to address all the other issues that are also relevant to tackle cancer. So many policy areas have made contributions and proposals for actions in the plan. On top of that, we've consulted extensively with all the stakeholders to prepare the plan. We've listened to the stakeholders. We've had many meetings with them. sometimes under very difficult circumstances because it was during the pandemic, so it was not obvious. But we managed to within 1 year to come up with Europe's beating cancer plan. So I think that's already a good indication that we take cancer serious. There's also strong political backing at the moment for cancer. I'm sure you know that yesterday the mission on cancer was released. So now there are two big initiatives in Europe that deal with cancer, the Europe's Beating Cancer Plan and the mission on cancer. And both have considerable budgets, and both will influence the policy, the research, and the care in the coming years. So these this sets out, I would say, the scene for cancer policy over the next years. On top of that, we've ensured that the necessary funding is in place, and we've ensured a let's say a governance to well implement the cancer plan. We're doing it with the national governments in a dedicated cancer subgroup. We do it with the other policy departments in the Commission. So there's a coherence of funding, coherence of priority, coherence of actions. And we also work closely with stakeholders. We had a first meeting with the stakeholder community a few months ago during the European Week Against Cancer, if I'm not mistaken. And now we are in the process of preparing the second meeting, which will take place in the autumn, where we will sit down with the stakeholders again and propose some ideas on the way ahead, how stakeholders can help us to implement the different flagships and the different actions of the cancer plan. Thank you.
Thank you, Stefan. Janelle, would you like to offer some comments or some feedback on the previous speakers and reflect on the broader presentations, the overall presentations? Over to you.
Thank you, Panos. I'm going to give my comments as being my previous hats, being a researcher, being a doctor, seeing cancer kids in treatment, and then also for over 20 years working at the United States Senate as a government official, and being in charge of the health committee and having to make real decisions on policies, and then also the United States State Department. And I think, as Antonella, commented, we have made great progress in the innovation and the data and the science. And it is so thrilling to see groups like the European Patient Coalition being part of panels, being part of discussions with our regulatory agencies. I mean, I just look back on writing different laws for FDA and having to write in there, patient input needs to be included. And I just can't believe a world that we had to do that, and again, as we say, patients, that's our moms, our dads, us, as we're going through these things. And so I'm really glad to hear this dialogue. I also am heartened to hear that as we've had these advancements, we're seeing great disparities within the whole person as they go through this end-to-end journey, but then also with governments and the changes and the differences in access on socioeconomic status. And I think these are the disparities that we have to get after, because this is a multifactorial issue. Great to have all the innovation, but if people are not actually having access to them, then that's shame on all of us. And so I'm thrilled that we're coming together. I understand it's complicated because not all health systems are the same. Not all countries are the same. So I just want to say, we want to lean in and we want to partner with you all and others to really get after this and tackle this issue so people don't just go through the journey, but then they are able to have a real quality of life following treatment as well. So thank you, Panos.
Great, thank you, Janelle. Francesca, over to you.
Sure,
clearly a lot of advancements, but also quite a lot of challenges. So how do you see that, all these from your OECD perspective? Also as an analyst, I mean, that's extremely important to reflect on.
Yes, so I'm less involved in analysis right now these days, but I think much has been said. I mean, lots of progress. Perhaps a couple of things that have not been mentioned that I would like to highlight. First, in terms of the efforts made with prevention and screening, yes, we talk a lot about treatment and so forth, but I think we should not forget that a number of countries, at least across OECD countries, most of them have population-based screening program for cervical and breast cancer, for example. There are programs for vaccinations, again, HPV, that really have taken foot in many countries. There have been in countries where the population is more susceptible to where incidence of certain cancer is higher, like melanoma cancer. Think about Australia, but also New Zealand, United Kingdom. There have been tremendous efforts to raise awareness, and that combined obviously with immunotherapies and target treatment, that has really made a lot of progress in terms of the outcomes that we get. So I think that should also be put on the equation. In terms of the challenges, I would concur very much with the issues of inequalities there, and there remains significant cross-country and also across different socioeconomic and ethnic group differences in things like screening and survival. And when we look also over time, there's been little change in the relative size of the inequalities across, and also in the country's ranking in a way. So somehow we're perhaps raising the bar, but we're not managing to address those inequalities. It could be linked to differences for geographical reasons, difficult to travel and so forth, but there are definitely socioeconomic reasons behind the lower level of awareness, linked also to people having lower income or coming from minority group, that needs to be addressed. It has not been mentioned, the challenge also of end-of-life care. Of course, I know that we're talking about having treatments for people to survive, but there are tremendous differences and challenges for countries in managing that particular parts of life. Huge opportunities with big data. Definitely there are still challenges linked to the implementation, also the GDPR and so forth. But if we look at data linkages, for example, across different data sets and in countries, I would say that for disease specific and particularly for cancer, that's that's one of the data sets that is more frequently linked with other types of data sets. So there are definitely opportunities here for improving surveillance, monitoring, but also research. And there are a number of even international initiatives for sharing cancer registry data, which are taking place in a number of EU and OECD countries, using the identified national cancer registries that can be really shared with appropriate foreign researchers to facilitate improvements in research. So I think there is a lot of opportunities with that, perhaps a little bit less in really the true using of big data, bringing also together not just the clinical data sets and the routine data, but also more genomics data and broader deep research data all together to really make advancements. So that's probably an area for further improvement.
Brilliant. Any reflections from our earlier panelists at all? Any issues that they see from their own perspective? And I'm looking at Maria, I'm looking at Manuel and Claudio. Any quick reflections? Maria.
To this long list, I would add concerns with data security that patients may have, and we sure now of the recent scandals around the globe that concern that, and I think that might be a big impediment to better policies unless there is a way to make sure that citizens trust the data, and that in a way we have a more democratic approach to data ownership, as I said earlier. So
excellent. Any other points, Claudio, Manuel?
Yeah,
very quick one, so I can actually progress. Thank you, Claudio. Over to you.
Yes, very quick. I think that one of the big issue is, I would say, adapting and continuously innovating the value frameworks, not only from a technical viewpoint, because, for example, you have talked about a lot of preventive care, but also for treatments. We have now agnostic treatments, and the value framework for this treatment is very difficult. So basically, I think that it would be great reflecting and pushing towards a common framework. We have discussed it a lot at the European level. The compromise that has been reached is not satisfactory, I mean, in my opinion. So basically, it would be great getting more and more on the value framework. And as far as equity is concerned, it is obvious that equity depends on a number of aspects, including the way the clinical pathway is managed. So access to diagnostic procedures, access to care, but also, unfortunately, as we know, it depends on budget constraint. So basically maintaining the flexibility in the way market access is managed at national level would guarantee that market access is guaranteed also in those countries where either the availability or the willingness, unfortunately, to pay for health is lower than the others.
Thank you.
Yeah, let me add. Basically, I agree with all the comments that have been raised so far. The other thing is that as Claudio was mentioning, there are very different types of cancer and very different types of treatments, and we are usually trying to get a tool that is valid for all of them. And many times we have to be flexible and see that sometimes the tools are valid for some type of cancers, but some others are not. And therefore we need to be kind of combining different tools in order to check how to be flexible and get access to for everyone, for all the authorized treatments. So the key question here is to improve access so that everyone gets access to the treatments, but we have to keep in our minds always that we have to sustain, we have to have the sustainability of our health systems. So budget constraints are going to be key also in this sense, but being flexible. Flexibility is the word I would say that is more important for setting prices and providing the tools.
Great, thank you. Thank you, Manuel. Now, what I wanted to do is invite our panelists to think about the future a little bit, and maybe offer us some thoughts, some ideas about how to take cancer care forward in the next, let's say, 5 years or so, and what kind of changes, or how should for example, health systems respond to what are known as fiscal challenges. And I think it goes without saying that we will be facing fiscal challenges based on what we've heard so far about increasing burden of disease, about increasing need in chronic diseases, and so on. And that takes us into perhaps the direction of prioritization, and perhaps reflect on maybe that there's a need to have some priorities. And if that is the case, then what should we be prioritizing first? So that we improve cancer care in a continued and sustainable manner. I think that's one thing. There's another thing here which also reflects one question that we have received. How do we ensure that we include all stakeholders in the decision-making process? But that's something that we can probably reflect on separately. I would like to go to once again have a round with Antonella, if that is possible. How do you see the future from an ECPC perspective, Antonella?
The collective shock brought about by COVID-19 and the realization that health systems that function poorly during normal times will break during a crisis should rally policymakers at different levels to undertake more far-ranging reforms. So it is important to ensure more flexible and integrated health funding frameworks to allocate the resources where they are most needed and when they are most needed. So the pandemic showed clearly that health and good health is at the basis of any sustainable economy. So the health crisis impacted on any social and economic aspects of the society. Mm-hmm. So the situation we are still living now shows clearly that health is the most relevant investments governments can make. Of course, we should find ways to measure and show the return on the investment on other sectors, such as the labor market, social security, trade, education, etc., and incentivize this way more investments in health. To do so, we need to find ways to break down the silos between different budgets and departments or ministries, for instance. So health systems should make sure that there are sufficient monetary resources and flexibility to reallocate and inject extra funds. Now, I don't know if I can go on, or you wanted just a few minutes.
If I could pause you there, I quite like what you mentioned about the allocation and the reallocation of resource. That doesn't mean to say I wanted Stefan to reflect on that one. But Stefan, how do you see from your perspective, and in particular, the cancer plan that the European Commission has put together going forward, and evolving and taking it further in the next 5 years?
Mm-hmm. Well, I think we've put the main building blocks in place. We've ensured a close cooperation with everybody, with the member states, with stakeholders, and also internally with other policy departments. So that's important. But there is let's say a strong basis for the next 5-10 years. And I also believe that we should realize that governments and health authorities alone cannot address the challenges posed by cancer. There are two economic aspects, social aspects, health aspects, of course, and we need everybody involved. The issue of limited budgets and limited resources is already mentioned. So that's, I think we should be very careful how we proceed on that. One way is also to step up action more on health promotion and disease prevention. So that would also ease the pressure on healthcare systems and on social protection systems. And that would also ensure a healthy workforce in the future. So more action and resources should also go to health promotion and disease prevention in order to ensure the sustainability of healthcare systems in the future. So that would be my my response.
Thank you, Stefan. Janelle, from a supply side perspective, obviously you're looking at some of the fiscal pressures that countries and governments are facing from your side, but I wanted to invite you to give some food for thought.
No, thank you very much.
Mm-hmm.
You know what I think we've learned, even more underscored with the pandemic, is that we cannot have a lack of creativity as we're looking at dealing and tackling with complex issues like this. And as Stefan has said, I cannot underscore more with Europe's beating cancer plan. It doesn't just have good components in there that we hope, like our oncology grant program, can complement that. It also has a vision. And that is what we all have to challenge ourselves, is not to get stuck in the box, right? We have to think outside the box. We owe that to people. We have to do that. And then I'd also say OECD with the whole cancer care pathway. I mean, we have these tools here. We have to harness them, harness the greatest minds, young and old, and look, how can we, you know, live up to what our moms, dads, and our neighbors, they expect us to do, help them live quality lives. So
fantastic. Thank you, Janelle. Francesca, over to you. fiscal pressures, prioritization. Sounds like OECD work, right?
Yeah, sure. We work on lots of that, but just some very quick question. First of all, I think there is a window of opportunity because now the discourse is actually as health and investments. It was recognized in the G20 declaration, in Rome. There will be a meeting of health and finance ministers. Those are the things which are being discussed. How can we invest more in health? So there is a opportunity because surely very soon also Minister of Finance will realize there is a huge deficit to be repaid. And so in that window of opportunity, I think that's where the transformations can happen. And some of the things that have been mentioned, the prevention, which has tremendous returns on investments. We've done lots of work on that, but also the digitalizations for understanding how to improve the treatments, but how really to use data to support better research, better care. I think there are new models of care which are emerging following the pandemic. Again, telemedicines, things that break down a little bit the silos across different sectors that can be leveraged upon. So I think we, in a way, have now the time to try to change the system so that when the budget, cuts may come, or the pressure will become more stringent, we are in a better place and much better position to have a health system that deliver better to people. And I forgot, but critically, obviously, the measuring of outcomes, which for an important aspect. So we still know way too little about how much the spending that goes into health system delivers to patients.
Fantastic. Thank you very much. And of course, the pandemic has offered us a lot of insights and a lot of extremely good food for thought about the ways forward. It's extremely fortunate to have all of you here as panelists presenting research, reflecting from a key stakeholder perspective. It's extremely unfortunate that we have come to the end of our allocated time, and the session has to come to an end. I want to thank each and every one of you for making this happen. The research has been great. The insights have been tremendous, and our stakeholder panelists from the Commission, the patients, the OECD, and obviously Janelle from industry has been hugely valuable. I wanted to thank MSD for supporting us in this initiative, and of course the forum for providing the enabling platform to make this happen. Thank you all very much, and no doubt we will be seeing each other very shortly once again. Thank you.